I'll just give it another few seconds while everyone's coming out of the waiting room and joining us. Okay, great. Welcome, everyone. Thank you for being here. Happy Tuesday. I'm very excited to see so many folks showing up for this presentation and discussion today. My name is Kirsten Forseth. My pronouns are she and her, and I am a member of the Drug User Health Team at NASTAD. And we are one of several partners who have collaborated to set up this syphilis and drug user health webinar series. This is the third of 5 webinars in the series. So glad you all could join. The next 2 webinars will be, the next one is at the end of June, Tuesday, June 27th, same time. And the final webinar will be at the end of July, Tuesday, July 25th at the same time. So we've kind of explored generally the intersections between drug use, drug user health, and syphilis. We've talked a bit about congenital syphilis and working with pregnant and parenting people who use drugs. And today we are going to explore a bit more about the syphilis epidemic in Indian country with some fabulous presenters. I just put in our info page into the chat that will allow you to view recordings and slides from the previous webinars. And you can also find registration information for upcoming webinars on that page. So very, very excited to have joined together with AIDS United, with NACCHO, with NCSD, and with the Northwest Portland Area Indian Health Board to put together this series. A few like logistical technical notes. I'll be handing it over in a moment to our presenters, and they'll share information from their experiences, and we'll save questions until the end. So we'll have plenty of time to do some Q&A at the end. Feel free also, if any kind of comments or questions come to mind as folks are presenting, to just drop that in the chat. We can either address it in the moment, or we'll be monitoring the chat and saving any questions so that we can bring them up at the end during the Q&A period. This meeting is being recorded, and so we'll post the recording on our website probably within a week of the webinar, and we'll also send it out to anyone who is registered for this session. So if you know anyone who registered and couldn't attend, the recording and the slides will be made available. I think that's about it for my part. So just very, very excited to everyone who's joining us. And I will pass it over to our first presenter, Jessica Leston.
Amasa Neat, Jessica DYU. Hi, everyone. My name is Jessica. I use she, her pronouns. I work at the Northwest Portland Area Indian Health Board. The Health Board serves the 43 tribes of Washington, Oregon, and Idaho. But the work that I do at the Health Board and my team does at the Health Board is national in scope, and we work closely with the Indian Health Services HIV, hepatitis C, and STI program to go to all of the IHS tribal and urban clinics and assist them with whatever it is they may need at the moment. And at the moment, it is syphilis, because it's still going on, it's still happening. You know, things need to be done, right? I think everybody in this space understands like the urgency of syphilis right now. And that is specifically true in Indian country. And we'll go over a little bit of that today. I'm going to start with a case. This case was presented last week during syphilis grand rounds on congenital syphilis. And as I listened to the case, I had some thoughts, and I'll get to those at the end. But Tiffany is 17 years old. She presented to the emergency department in late October of 2022, reporting symptoms of a UTI, not a UIT. When tested, the UTI came back positive. It also came back positive for pregnancy. And this facility was very fortunate within the IHS tribal and urban health system in that it had an ultrasound and an ultrasound technician who was there. And they were able to do that. And she was 14 weeks pregnant. So during this visit, she was treated for the UTI. She had prenatal labs drawn and sent, and she was referred to the prenatal clinic. So that was this visit. The results of the prenatal labs included an RPR, which came back at 1 to 128. She had a positive TPPA and a positive chlamydia test. All of her other labs were negative or unremarkable. So multiple phone calls and a public health nurse visit later, Tiffany presented to the clinic in early December of 2022. So 2 months have gone by. She has a rash. She reports that she's no longer with her partner, but declines to name who this person was. So during this early December visit, she was treated with bicillin for secondary syphilis and azithromycin for chlamydia. She had prenatal care done and an ultrasound arranged. The day of treatment, she had her blood drawn again for the titer, which returned at 1 to 64. So in late January, after several missed visits for prenatal care, Tiffany returns to the clinic for an ultrasound and her prenatal visit. Her labs were drawn during that visit again, and her RPR was 1 to 128, and she was positive for chlamydia. So in early March, after extensive outreach efforts and missed visits, the public health nurse at the site found her at a house associated with meth use. She had reunited with her partner, Marcus, who was never treated originally, right? Because they had split up and she declined to name who he was. So that same day, this amazing public health nurse who was at this site treated Tiffany and Marcus with field treatment. And was able to screen and draw labs for all the other STIs. Follow-up care was arranged for Tiffany, and also follow-up care was arranged for Marcus for staging for syphilis. Despite extensive outreach efforts, Tiffany is next seen in early April in labor and delivery. She was 36 weeks and 5 days. She had elevated blood pressure and apparent intoxication. She was screened and was positive for methamphetamine. She progressed rapidly in labor and delivered a 5-pound, 14-ounce baby with Apgar 7 and 6. So Tiffany's baby, the maternal RPR at delivery was 1 to 16. The baby's was 1 to 32, and there were no obvious findings with congenital syphilis. But the baby had respiratory issues and was transferred to an outside NICU. Baby received full evaluation, including CSF analysis, and she was treated with penicillin for 10 days for possible congenital syphilis. So at the end of the day, baby and mom were both treated, but they've been subsequently lost to follow-up. A family reported they had left the area for sober living in another state. So this case was presented for the reasons of complexity, for the reasons of reinfection, for the overlap with substance use, specifically methamphetamine use or poly use, that is so common with syphilis diagnosis now, specifically in women, and for sure with a lot of the congenital syphilis cases. But as the OB/GYN was presenting this, my head went to Tiffany. So this is the case presented from the point of view of the health system. But what does this case study look like from Tiffany's point of view, from the very beginning to the very end? For that initial visit to the ER, how hard was it for her to get to the ER on that date? For follow-up, when she did make her appointments, what did it take for her to get to those appointments? On multiple different levels, on transportation levels, on is somebody controlling what it is she's doing? How are drugs coming into play? Also, let's hope my software doesn't update right now. Also, if she's pregnant and people are wanting her to come back for prenatal care, if she's using, is she scared that her baby is going to be taken away from her? Because just because she's using doesn't mean that she wants her baby taken away from her. And so there are all of these things from the point of view of the person who has congenital syphilis that I don't think we are addressing. And if we don't address them, I think this epidemic in congenital syphilis cases and in syphilis in general is just going to continue to go away from us, because the health system is not set up for people who use drugs. And we need to rethink about what access to care is for people who use drugs, one of the most disenfranchised populations. So switching a little bit to epidemiology, this is a congenital syphilis reported cases by state, and it was ranked. So these are the top 15 states by rate. You'll see Arizona and New Mexico, Oklahoma and South Dakota and Montana. These are states that have really high case rates in the American Indian and Alaska Native population. And I would say that these case rates in these states are fueled by the outbreaks in American Indian communities. Just to hit that again, a lot of the places on this map that are blue that are not in traditional urban or suburban centers overlap with Indian country. They overlap with reservation space. They overlap with tribal lands. I see Ginny sort of smiled because she could probably tell where she is in Minnesota is one of the dark blue spaces here. Andrew is presenting on behalf of Maria from Fort Peck. And so if you look at Montana, you can see where that is on this slide. So even though there's more people in those urban centers, it is just as important that we continue to provide the best care to rural and reservation spaces, especially when you're dealing with really small communities that have historically had really bad access to healthcare services. This is the first year that American Indian and Alaska Native rates of reported primary and secondary syphilis has surpassed the Black and African American case rate. This is really important. I think that as I presented on those last two slides, there are a tornado effect of factors that are fueling these increases in American Indian and Alaska Native communities. And the infrastructure, the capacity isn't always there in these spaces to address what's going on. On top of that, if you look at primary and secondary syphilis broken down by race and ethnicity and sex, you can see that, of course, there's going to be more syphilis cases in men. But if you're looking at the rates male to female, you'll see that American Indian and Alaska Native females have higher rates than other females, like in the Asian population and the white population, you know, and they're more than the Black, African American, and Native Hawaiian and Pacific Islanders. This is really important because as the cases of syphilis go up, specifically among 15 to 44-year-olds in the United States, women, so do the cases of congenital syphilis, right? I mean, congenital syphilis is not an STD. It's a vertically transmitted infection. The pregnant person has the STD. And so really, in order to address congenital syphilis that's happening right now, we need to increase testing and treatment in women of childbearing age. Just another example of the case rates and also the cases. So yes, American Indian and Alaska Native people only have 102 cases of congenital syphilis, but that accounts for almost a 400 per 100,000 case rate. It's just affecting the population much more because the population is so tiny to begin with. And again, this is American Indian, Alaska Native congenital syphilis rates compared to other race and ethnicities. So the urgency of addressing syphilis and congenital syphilis is very apparent if you look at the data. And it's very apparent if you are seeing patients with syphilis. If you are in a community of a couple thousand people and all of a sudden you have 10 cases of syphilis pop up where you've never been treating syphilis before, and you don't have any DIS, and you have one public health nurse who's also doing well baby visits and diabetes care and all of this other stuff. So like the system in general is not set up to respond to outbreaks like this. And there are multiple factors that are contributing to the rises in syphilis and congenital syphilis. Lack of prenatal care. I mean, really in a lot of these areas, you have to drive like anywhere from 2 to 4 hours for prenatal care. It's not being done at your local health facility. There's a lack of screening. There's a lack of treatment. It's really difficult to do partner services and traditional DIS work. Many tribes don't have their own DIS, so they're working with the state, with the local health jurisdictions in order to do that. And drug use and mental health and other social determinants of health are all playing into the syphilis outbreaks in Indian country and the overlap with mental health and drug use. So last year, the Indian Health Service and key partners put together a syphilis crosswalk. It took documents that previously existed, syphilis elimination plans that previously had been in place, and brought them all together to provide a template or a checklist that facilities could use in order to best respond to the syphilis outbreak as it is. These include improving and enhancing syphilis surveillance outbreak response. For instance, a lot of tribal clinics, IHS clinics don't have access to the state reporting system. And when you don't have access to the state reporting system, you don't necessarily know what's going on with all of the cases, and you can't see what's happening and what other people are doing to find people. So it's been that, for instance, has been a big issue. Improving quality clinical and partner services. As I mentioned, I think it would be best practice across states to have specific DIS that are placed at the tribe or the clinic to be able to be doing their own partner services, somebody local from the community or someone who can be brought in from the community, because people who are from the outside, in most cases, don't know where people hang out. They don't know where they can go to find a group of people, and the people may or may not trust them. Improving laboratory services, including things like the new dual syphilis HIV test, mobilization of affected communities. And I don't think that we're doing this enough of working directly with communities to see, like, there's been an outbreak going on a tribe for like 2 years now, but there's no community understanding of that. There's no signage, there's no outreach and education. And so, what the community doesn't know will hurt them. And then tailoring intervention strategies for affected populations. For instance, specific interventions for people who are using drugs, specific interventions for women or persons who are pregnant, specific interventions for people who are incarcerated, tailoring it to the smallest level. And then increasing alliances between healthcare providers and professionals. So increasing the collaboration between state, local health jurisdiction, and tribal clinics and tribes is just really important. And I think that in places where there is syphilis outbreaks going on, if this collaboration doesn't exist, nothing is going to move forward, and syphilis will remain unresponded to. So a couple more: training and staff development and action planning. But if you wanted to have a look at this crosswalk after I'm done talking, I will put in a link to it, and happy to go ahead and use it, provide comments back to me. This is the link to it. And happy to have more conversations about what that crosswalk is, really through the eyes of the IHS and tribal health system. A couple of other things. Let me get a time check. What time is it? Okay. A couple of other things that we have. We know the importance of creating plans of safe care for people who are pregnant and their families. Our plans of safe care is divergent from the traditional plans of safe care, which are very child protective services focused and reporting focused, and that our plans of safe care are really about wrapping the pregnant person and their family in a system that supports the pregnant person and their family, that is specifically designed for that pregnant person and their family. So this pregnant person who is using substances and doing everything possible to treat the pregnant person, to keep the family together, and if appropriate for that pregnant person, also treat them for their substance use disorder, if that's something that they're interested in. It's this plans of safe care that we've developed is really about a comprehensive integrated model of care, to fill in the cracks of the current system that exists for pregnant people who are using substances. And I will also put in the link to our plans of safe care after I get done talking. So a couple of the innovative ideas that are in that plan of safe care are to increase transportation options, to develop on-site childcare opportunities, because maybe some people aren't making their prenatal visits because they also have 2 other little ones running around, and they don't know they can't find someone to help them, or maybe they have they're providing elder care to someone in the family and they literally don't have the time for themselves to go in. Advocating for transitional or recovery housing, establishing a tribal healing to wellness court, and establishing inpatient facilities for parenting and pregnant people that allow children and allow the family to stay together. So those are just a few of the things that IHS and tribal and urban health systems are working on. And I will go ahead and hand it over to Jenny Meyer from Cass Lake now.
Hi there. Just wanted to make sure everyone can hear me. Thumbs up? Yes. Okay, Great. So my name is Jenny Meyer, and I use the pronouns she, her, and we're just gonna switch it a little bit here and talk about harm reduction and focus a little bit on those that use drugs. A little bit about myself, as you can tell, maybe a little bit. I'm a commissioned court officer. I am not Native. And I guess I wasn't planning on focusing on this, but listening to Jessica a little bit, it made me think about a little extra that I might mention, but, and as long as I started it, I'm gonna start with it. But one of the biggest things is to entrust a trusting relationship with our patients. And that's something that we really focused on our harm reduction program. And we'll talk a little bit more about that as we go in, but that is something that we really focus on with our training, and that we noticed that grew with our patients. So I'll start with a little, I'll tell some stories as we go on. And that was something that I had to learn as a commissioned court officer and someone who's not Native, that it literally took me years to develop relationships with our patients. And now that I have been here for 17 years, I have great relationships with my patients. So for someone who's new, maybe working in Indian country, just continue to be yourself, and eventually you'll be welcomed into the community. It just sometimes takes time because there's a lot of history with our patients. So it's a very rewarding. So we just need to stay with it. Okay, so let's get started. So we can just go to the next slide, Jessica. Okay, so the first thing is we identified a need to have a harm reduction program here at the Cass Lake IHS, which Jessica alluded to. We are in northern Minnesota when we were talking about a syphilis outbreak. One of the first things is we have a hepatitis C treatment program that is taken care of by pharmacists here. And initially we looked at all of our patients. So in the first pie chart, we see all of our patients, they identified IV drug use as their primary risk factor for the hepatitis C infection. Then when we've taken care of them, that was like in our first 5 years when we had our new pharmacist that took care of our hep C patients. Then when we've taken care of, we got our last 50 patients, we kind of got the baby boomers taken care of. We really identified that primarily all of our patients, 90%, have IV drug use as their risk factor. So we really hit the nail on the head that said, you know what, we really need to move forward and figure out how are we going to do a harm reduction program in an IHS facility. Okay, Jess. So first was, is there any near us? So on this map, there's a lot of lines. So this, if you can kind of see an I Spy in here, this is Minnesota in here. Yes. Leech Lake Reservation is the reservation that Cass Lake is located on. A little north of us there is where Red Lake IHS is located. The other little dark spot on there is White Earth, which is not labeled. The other, Fond du Lac. So then we have all these little thought bubbles here are places where there is a syringe exchange. You will note there is nowhere near where we are located. Okay, so for one, we've identified there's nowhere near for our patients to get syringe services. Okay, next slide. So for one, we started, okay, we're seeing a lot of hepatitis C. We've identified that because we were treating patients with hepatitis C. At that time, pharmacy was not involved in syphilis or any other STIs at that time. We noticed there were no syringe services anywhere. What else were we seeing in our ER was the next easiest place to get STD or STI testing. Well, for in the ED, you need to have a medical screening exam, which is not quick and easy. A lot of patients either checked in and left, or they never even came in. So there was a need for something that was quick and easy. For the patients who were identified with a positive syphilis case, which were either identified through maybe a prenatal visit, or they did make it through an ER visit, or we do work with the Minnesota Department of Health. Their contact tracer personally calls myself or my colleague and says, hey, we have a patient in your area that's eligible for care. They're going to come in today and get a dose. I have, we're almost on speed dial with each other. And then getting to know that patient. They also are someone who uses IV drugs. Sometimes they do, sometimes they don't. And also additionally, we have a lot of, unfortunately, fentanyl use in our community. So we needed an easier way, fast and easy way to get naloxone into the community. So we were hoping to utilize our harm reduction program to get that out into the community. And many of those patients that were overdosing with opiates were not impaneled, did not have primary care providers, which I'm sure is not shocking to anybody on this call. Okay, so where to get started? We were stuck in the where to get started phase for a very long time. Couple of the things we did was meeting with our tribal counterparts. There was a lot we did there. We did have support with our tribal health counterparts. They were very supportive. They helped a lot by being the talking head with the tribal council, talking to elders. Those two very important groups of people in our community had a lot of concerns about a harm reduction program. They had a lot of misunderstandings of what that means and how that could benefit our community. So that took a lot of time. But eventually they did at least agree to the program, agree to have the program. We met with the tribal police. So this was towards before the inception of the program or starting of the program, the tribal police. So they understood what was going to happen in case they encountered any of our patients. One of the other big hurdles we had to try to overcome was, how does a federal facility procure a lot of the supplies that is needed to have a successful harm reduction program? Because we cannot use federal funds to purchase things like syringes that are used for these types of uses. I wasn't sure how to word that. So we talked to our finance people, and we were able to utilize funds that we procured from insurance reimbursements. So it was not funds that we received in any federal way. So if there's any federal facilities on there that they're finding that as a barrier, you definitely get a hold of me and I can help you with that. Because that was a big sticking point for us for some time. We had to make sure it was approved by our facility leadership. Thankfully, they were very on board. Our medical staff was on board. This department or this program is in the pharmacy. held within the pharmacy department. So I had to make sure that all of my pharmacy staff is trained, on board, and can make sure they can provide the service unbiasedly. And so we were at this stage for a very, very long time. So yeah. Okay. So once we got all that smoothed out, it's been really, really good sailing. So what we have right now at our harm reduction services, what we provide to our patients, physically give them, we have syringes, we have sharps containers, naloxone, and we provide the 8 milligram nasal spray for them. Like I stated, we use a lot of, I do not, our community uses a lot of fentanyl. So we have the 8 milligram nasal spray. We have safer sex kits, we call them. So they have condom and they have lube in them. We have safer injection kits that have, I'm peeking at them right now. They have single-use normal saline, tourniquets, alcohol swabs. We offer STI testing. We offer education and handouts on safer injection practices. We offer education on, if they're interested in quitting, and mental health services that are all, and they're all specific to our community. So we are very rural. Transportation is an issue. So they're very tailored to what is available in our community. And there are things that are maybe like just available like by text or by phone for those who really, really live rurally, because there's some people that can't make it in, Okay, so say a patient presents, we do try to have them fill out a voluntary intake form. This is completely voluntary. It tries to capture data. So myself and my colleague who manages the program can better provide services. So it asks questions like, what drugs do you typically use? So we know that typically our patients who participate in the program, they usually use opiates or they use meth. What kind of partners do you have? Are we seeing like same-sex partners, heterosexual partners? Do you usually use IV drugs? Those types of things. So we can try to like pick and choose, or try to gather information after the fact. What we're seeing with patients is when they first come in, they're really hesitant. Usually they'll fill out the form, but you usually see hoodies on, glasses on, head down, whispering, okay? And we don't take names. We do have a binder with their names written on it once. Otherwise, they just have a number. We don't use names and it doesn't get targeted anywhere. Because I don't have a lot of time, we work with the tribe, kind of talk about that. We can go to the next one. Okay, so this is a better thing. So we started this around Halloween. We currently have 31 participants. So those first couple people that came in, they come in with their hood on. Now they're like, you see them in the hall, you give them knucks, like we're best friends. They're like, hey, Jeannie, what's up? Okay, like, and they would like come in and they would be like, come in every day because they're getting it for like their brother, their cousin, their whatever. Now their brother and their cousin come in and they're like, Nux, what's up? And like we're besties, right? But it took like, a month for them to be like, are they gonna call the cops on me? Are they going to do whatever? So it takes a long time to get them to trust us. So you can kind of see our age gap is like, you don't want a stereotype to be like, oh, they're the 20-year-olds, because we got a couple people, you know, we got a 67-year-old guy, you know, our median ages. Majority of our patients, 77%, don't have any primaries. We provide 106 naloxones over a couple months. Basically, our patients come in, they ask what they want, they get whatever they want. It's like a store. Downfalls. Only 6 visits out of 138 visits have ever got STI testing. This is the downfall. As their supervisor, I don't know if it's not my staff asking them, do you want to get tested or not? Or if they're just like, hey, dude, what's up? Good to see you. I haven't seen you since last week. Or if it's the patient's like, nah, I'm fine. I don't need it. I don't know.
I've heard that it's just one person asking if people want any kind of STI testing.
Right. So if it's myself or my colleague that does the visit, we're going to be like, hey, what's up? Let's go over and get tested. Right. I don't know. This is the downside, is that it needs to get tested, because if you go back and look at that last slide, Jess, of the 6 visits, everybody was positive for at least something. Positive for Hep C, positive for syphilis. So they need to get tested. So that's the downside, is like the staff is making connections, but are they asking for STIs to get tested? Good side is we're working on getting incentives to hopefully get our patients tested, because it needs to get asked every visit, every time. It needs to get done. We do not have point of care testing, which also is a barrier. Maybe we could do it while we're getting their stuff ready. I don't know. Be flexible. We all should know that, because these are our patients that we take care of. Alternative forms of communication. However we can get a hold of them. We use the tribal too. Like, we have someone in the community who's like amazing. She can like find them, I don't know where, but she's great. I should not have this little of time to talk. I'm sorry I talk fast. Hopefully you can understand my Minnesota accent. I'll try to answer the questions in the chat.
Thanks, Jenny.
Sorry.
Thank you. And now Andrew is going to present on behalf of Maria from Fort Peck, because she has a much deserved day off today.
Hi, everyone. I'm Andrew Yu. Pronouns are he, him, and I am the National Clinical Coordinator for the HIV Hep C STI program at IHS headquarters. I am filling in for Maria Vega, the public health nurse at Fort Peck. Next slide, please. Brief overview on Fort Peck, located in rural northeastern Montana. We have 2 IHS facilities, one in Wolf Point and one in Poplar. These are ambulatory care clinics about 20 miles apart. We also partner with tribal health programs, as well as the local health jurisdiction of Roosevelt County. There is a private hospital in Wolf Point that has urgent care emergency services, and an OB clinic in Poplar, which is also non-IHS or tribal, but the majority of patients are referred there for their OB care. Looking at the state of syphilis in the state of Montana in 2022 versus 2021, we've seen stable rates of chlamydia, a slight decrease in gonorrhea, but of course we all know syphilis cases have exponentially increased. In Montana, there was a 178% increase in syphilis of all stages and 67% increase in congenital syphilis cases, including several stillbirths. And when looking at who is particularly vulnerable due to poor health outcomes, the vast majority of women diagnosed with syphilis in Montana were of childbearing age, and 2/3 of those women were Native American. And zooming in on Fort Peck, looking at syphilis cases between 2020 and 2022, there was an over 2,000% increase in syphilis. And when looking at congenital syphilis, we saw 4 cases in 2021, 6 cases in 2022. And so far in 2023, we haven't even made it to June. We've seen 5 cases of congenital syphilis so far this year. And from January 1st to May 9th of this year at Fort Peck, there have been a total of 54 cases of syphilis. 37 of those cases are syphilis of unknown duration or late latency. This is concerning because syphilis at this stage requires 3 injections of bicillin a week apart. If you are using doxy to treat, that is 4 weeks of antibiotics twice a day. And the amount of resources and staff that it takes to ensure that everyone who is diagnosed at this stage comes in for their treatment and adherence to doxy, it takes a village. And as you can see on the right-hand column, that is why we still have 53 open cases of syphilis of unknown duration or late latency, where we still have not ensured that everyone diagnosed has been treated properly and has had their cases and contacts come in for testing and treatment as well. So here's a specific case recently on Fort Peck that really summarizes the challenges as well as the successes that the public health nurses have had with congenital syphilis. So in September of 2022, a female patient walked into IHS complaining of a chancre and a rash. So she had an RPR drawn, which had a titer of 1 to 128. Also was a patient of childbearing age, so she had a pregnancy test done, which was negative. And she was presumptively treated that same visit with 1 dose of bicillin for secondary syphilis. The patient also did not have stable housing, nor she did have a working phone. And so it was going to be difficult to stay in touch with this patient moving forward. She also was engaging in chemsex with the use of IV methamphetamines. In January of 2023, she walked into the ER and wanted a pregnancy test, which was positive. They redrew the RPR at that visit with a titer of 1 to 32. She did not report any signs or symptoms of syphilis or any known exposure to syphilis, so she did not need treatment at that time. She was also referred to a midwife at the OB clinic for her OB care. In April of 2023, she walked back into IHS because she heard that there were incentives being given out for anything related to testing and treatment regarding this endemic. And so she got a titer drawn, an RPR, which had a titer of 1 to 1. Again, did not report any signs or symptoms of syphilis or a known exposure to syphilis, so did not need treatment. A month later, she saw her midwife for a follow-up and did not report any signs or symptoms of syphilis or a known exposure. The midwife did order an RPR and it had a titer of 1 to 64. The midwife does not have access to the IHS medical record, which would have shown the 1 to 1 titer in April of 2023. So going based on the previous titer that she could see of 1 to 32 and based on the patient's sexual history, did not think that she needed treatment. Fortunately, the public health nurse, Maria, does have access to all of the titers drawn anywhere and saw that this was indeed a new infection. And so although she recognized that this was a new infection, because the patient did not have a working phone or a stable address, could not get in touch with the patient. The patient did, however, walk into IHS a week later seeking another incentive, which is why she was able to get treated. So incentives have made a tremendous help in getting people in who we normally would have lost to care. So pictured here is Maria in the middle, along with her colleagues. They were asked to speak at a health fair for students grades 6 to 12. They were pleasantly surprised to find out that a health educator had already come by and spoke to the students about syphilis in the community a few weeks earlier. And so they tailored their health fair really regarding the point of care testing on what it looks like. They were able to show the students, and the students can feel and touch as to what these tests actually look like, how quickly they got results, and then what the protocol would be if you were positive. And the whole point of this was to educate students as early as possible before the onset of sexual activity, to destigmatize and make it less scary to talk about all things sexual health. And speaking of those point of care syphilis tests, the ones that are being used right now in Fort Peck are the CLIA-waived rapid treponemal antibody tests. It's a simple finger stick test requiring 2 drops of blood and 4 drops of diluent, results in 10 to 15 minutes, and they come in a box of 20. The obvious benefits of using rapid point of care testing for syphilis, of course, is it provides immediate results, whereas the labs can take over a week, sometimes 2, as they are sent out on Fort Peck to result. This also allows for immediate treatment for those testing positive, and the ability to immediately contact partners to come in for testing and treatment themselves. And also, this can be portable and be done in the field. Some of the challenges are the possibility of false positives. When you look at the second test there is a faint line. If you ever use point of care testing, those faint lines can go either way. When in doubt, we call it as a positive. So there may be cases of us over-treating, but that's okay in the midst of an epidemic. Also, these tests aren't able to differentiate between prior treated infections from current infections, as well as response to treatment. So any positives will have to draw RPRs to get those titers. And finally, the public health nurses are utilizing their mobile health clinic 1 day a week. So they are parking their vans either at Wolf Point or Poplar, which is where the majority of the population lives on Fort Peck. And this clinic is solely meant to test and treat as many people as possible for HIV, Hep C, and STIs, with the focus on syphilis, of course. They are able to look up patient history. They have their medical records available and treat accordingly. Incentives are being used. The ones we use right now are $10 Visa gift cards. And follow-up appointments are always made for subsequent appointments if they need multiple shots of bicillin, as well as follow-up testing. And that is all.
Thank you so much, Andrew, and thanks so much, Jenny, for your time. We have 4 minutes if anyone wants to unmute and has a question.
Oh, Jessica, this is actually scheduled until 4:30, I think. So we have plenty of time for discussion for as long as folks are able to stay on, but can also, close a little early if that makes sense.
That's what I meant.
Great.
Hold on, let me grab that syphilis crosswalk for folks.
I saw a lot of chatter in the chat about different doses of naloxone, kind of kicked off maybe by the picture of the Kloxxado brand 8 milligram naloxone in Ginny's presentation. And I see a few questions here also about the point of care tests and kind of budgets for those and how tests are used.
I can just
Oh, go ahead.
Sorry. No, I can just touch base about how that decision was made for our site. And I 100% agree with a lot of the comments that were made in regards to naloxone and the really pleasant withdrawal that can come of it on the 8 milligram. Here on our reservation, there is a very, I don't know what the word is, strong epidemic, horrible epidemic. I'm not saying ours is any worse than anywhere else in Indian country. There is I'm trying to think of the link off the top of my head, but I will put it in the chat. It's actually a USDA link. I might be talking to the wrong group because y'all probably know it already, that talks about rates of opiate epidemics, but where I'm located, it is one of the highest in Minnesota. And so we have a high rate of fatalities due to opiates because people are primarily using fentanyl. And we have chosen as a community to rather have continual deaths that occur on the reservation, and to only have the 8s actually available. And because we give anywhere from, I mean, it's not uncommon to give 24 milligrams in the ED to make someone come back. And we have children that OD, and it's a horrible epidemic. And I'm not saying it doesn't happen anywhere else in any country, but it's very bad. And it is very expensive. It's probably $80 a nasal spray. We do not get reimbursed for it. It is something as a facility we decided to that it's important to save lives, and we'd rather people wake up mad at us than not wake up at all. So that's just a decision that we made, and our harm reduction patients pick it up probably every single visit. So I don't think it has deterred them at all. So that's our experience at our site. Everybody's site's different, and everyone's experience is different. So whatever works for you and whatever budget your budget can allow, I think.
So I see a question from Val. It says, with the rapid test, do you ask about signs and symptoms as well? That way you can find the best treatment. Yes, so whenever we do any type of testing, we always ask regarding signs and symptoms, as well as exposure to STIs, and offer treatment on the spot. The whole point of this is to get as many people treated, assuming that you'll never see them again. So if you have someone in front of you, do as much as you can as humanly possible.
And regarding the incentives, like having a higher incentive price point would be great. IHS still hasn't ruled on use of incentives, although there are IHS clinics using incentives. There isn't like a national policy set forth. So like I am personally ordering all of the gift cards like on my credit card and then getting reimbursed through my organization. So like I do use my credit card for personal things. So I usually end up ordering like 10,000 at a time, and then sending it out to all of the sites that are requesting it. And Melissa, the health board created the graphic. I put in our website where it is. It's www.stopsyphilis.com or .org rather. I can't believe like no one had taken that web address, but stopsyphilis.org, and you can order a bunch of different things on there. We do ask that it's reserved for American Indian and Alaska Native education and outreach, just because it's free. All of the orders are free.
I kind of want to throw out a question, if it's okay. So I see, Jessica, that you had commented that there's a great relationship in Montana between the state, the tribe, and IHS. I wonder if you or Andrew could talk a little bit more about how those relationships were developed and what sort of makes those relationships strong. Just coming from NASTAD, which is an organization that works with state health departments primarily. We're often trying to, convene different partners, make connections, facilitate partnerships, and would love to hear more about that.
It's really just about the person. Like, I wish it was like something like, we have this like policy set forth and there's like an open and honest, there's an open agreement, there's a data use agreement. So, all of this stuff, but like, really it is like having a person, from my perspective, right? Because I'm working within the tribal health system, it's having a person at the state at various different levels. Maybe the person is in policy, maybe the person's in Medicaid, maybe the person's in STD, like that is willing to talk to you as like a person that is on the same level as a local health jurisdiction, right? So knowing that there's tribal sovereignty and a government to government relationship should exist between the state and the local tribe and the local health jurisdiction and the local tribe. Just like there's a federal trust responsibility, there should be a state and a local trust responsibility as well. And oftentimes we see in some states that isn't the view that they take. It's very hard to get data information out of them. It's very hard in some states to get read-write access to the reporting system so that something could happen, like Maria is able to go in and see all of the titers for someone and know that someone needs to be treated again. If she didn't have access to this reporting system, she would not have maybe known that. It's just really important for IHS, federal clinics or tribal clinics to be able to have like the same sort of jurisdiction level as a local health jurisdiction. Sometimes that means creating another jurisdiction and it having, like, for instance, in the place of Fort Peck, have it be just Fort Peck. Or if it's, another tribe, it's just another tribe. But I mean, it's very difficult and it's all about the person-to-person relationship.
And from the clinician's point of view, it's a lot easier when that clinician is consistent and stays there for a while, right? When you have constant staffing changes, those relationships are harder to maintain. So with public health nursing, especially at Fort Peck, you have to figure out why are people leaving and what can we do to retain our staff to maintain those relationships.
And I know, Ginny, you mentioned that you work with a DIS that's employed by the health department. Is that right? So there's a partnership there?
Yes, correct, with the state health department.
Mm-hmm. I see a question from Jennifer kind of on that topic. Have you had any success in hiring DIS located within an IHS clinic from the community? They've attempted and have not yet been able to fill the position.
Yes, but are you talking about it being a state hire placed at the local tribe, or having it be like funds delivered to a tribe in order to hire someone in DIS? Like, as you're answering that, Jennifer, I can say that there are many levels of existing positions within the tribal health system that can be doing DIS work or partner services work. We saw this during COVID. There are community health educators, community health representatives, community health aides, and also medical assistants. There could be so many people that could do this DIS work. if there were training, like easy to access training for them, and also funding for them. I mean, we see in many places that if you look at a local health jurisdiction in which the tribal reservation is in, there is a DIS worker for that local health jurisdiction, but they're not actually even doing DIS for the tribe. The tribe is doing their own DIS and partner services work with no funding, with no training potentially. And so, you know, like the fact that the local health jurisdiction gets this money for doing this work and the tribe is expected to do it but does not have any funding, I think is one space where it could be improved, whether through like the Peach funding, like that it be you know, suggestion to hire local DIS in tribal communities, or give money to tribes to hire their own, which is like the best case scenario, or having that funding come directly from the CDC. But you know, just like in a healthcare like scenario where you're already underfunded and then you're expected to do the same work that others are doing and get paid for without any kind of increased funding.
It's Jessica. Yeah, I'm in North Dakota, and it would be state funds that would hire the person is the mechanism we began with. And we weren't able to find anyone interested in doing that specific. And so I know there was conversations started to have the money go to the tribe, let the tribe hire someone, and they're just taking more time than maybe we would like, because North Dakota has experienced an outbreak of syphilis in years past, and it is all around us as I listen to everybody. So just wanting to try to put some people into some places before we need them. And so I was just curious if there was any tips or tricks that you guys found to get those into places. And it sounds like we're doing what we can do, and it just takes the right people in the right places and the right amount of time.
Yeah, like all with the same goal. And it is really difficult to get everybody on the same, like to see the same goal, right? Because everybody also has all of these different competing priorities as well that they're dealing with. But I gotta say, no, I don't necessarily know of a place that is currently either funding the tribe to do DIS work or has a DIS at the tribe. I know of other people, like they're already employed at the tribes or within the clinic, who are doing DIS work, who are community health representatives or health techs or nurses or whomever. And I know that, you know, working with Oregon, we have been working the past year to develop like the background and need to show the need of having more DIS be out working at the tribe, in the tribe. Melissa, I've thought about that, about like getting an RV and going around and helping provide prenatal care. I mean, it really definitely like is needed in our most rural and remote spaces in Montana, in North in South Dakota, in Minnesota, those places where you know, it's like we're not getting, you know, OBGYNs out in these places and keeping them in these places. Like it's hard enough for us to like maintain primary care in a lot of these places, let alone specialty care. So all of the innovative ideas from telehealth models to mobile units. I think it's really rethinking what we mean by access to care. Like access to care, like you could live in a community and there's a clinic there providing like primary services, but just because there's a clinic there doesn't mean that there's like good access to care for a lot of people in that community for a variety of reasons. So I do think it's going to be a really like innovative and interesting space to be in, to see like what other models of care access we can provide moving into the future. Because I mean, people are just like, more and more people are going to be leaving rural spaces for urban areas, and there will be less and less people working in some of the more rural and remote places, especially as the baby boomers continue to leave. Y'all gonna put me out of business too with this $25 thing. The $10 is really working in our communities, so we got to keep it at $10 right now.
Are there any other questions from folks? You can either type them into the chat or feel free at this point to just unmute and ask a question. Oh, that's an interesting one. Can IHS access any of the national harm reduction funding? And Melissa, I wonder, what are you referring to specifically? Are you referring to federal funding that might come through the CDC or SAMHSA for harm reduction, or is there something else that you're referring to?
I am relatively new to harm reduction, but I think it's the Cheery funding. It's the black and yellow web page. I'm trying furiously to find it, but I was wondering if there was any sharing or jurisdiction. Because since it's a national, but I don't know how that interacts with the Indian Health Service. I apologize.
So IHS is a federally funded organization. They're just not under HHS. They're under the Department of the Interior, from when it used to be the Department of War. But they are funded out of the Department of the Interior, and you can use IHS funds for syringe services, harm reduction stuff, just not the needles. Like any place, like you just can't use the needles. Now, that being said, IHS is extremely underfunded. I will try not to wax poetic about this, but like in 2021, the national healthcare expenditure was $12,000 per person. The healthcare expenditure cost for that IHS gets per person is like $5,000. So, I mean, it's less funding than inmates get in prisons. So it's like we technically have the funds, but it might come at a cost of like being able to refer people to care after June. Like when a lot of the purchase and referred care, like funding is depleted. So, but we do like look for other grants. Like we have via the national offices, like minority HIV/AIDS funding, and we've worked with places that have gotten funds from other places.
And so we have utilized. So we're in Minnesota. So the Minnesota Department of Health has assisted us. There's roundabout ways to purchase them depending on what can you use through your financial department. So I can talk offline about how to do that, depending on what your budget looks like for your department. So I wear many hats, and one of which is I am the acting pharmacy director. So I know exactly what my budget is, and I can say yay or nay to ordering whatever. So I can do a lot of the ordering. I have not added up the money yet to see what our harm reduction has cost us this last year, but I do plan on adding that as a new budget item to make sure that we have the funds moving forward. But it actually has not cost us as much money as I thought, because there is a lot of assistance out there. But I can definitely touch base offline to get you taken care of, because it's not that big of a deal as I thought it was going to be. And sometimes the tribes will provide the funding for the syringes too, and anything else that the healthcare facility can't purchase or doesn't.
And it's a good question, because there isn't much dedicated federal funding for harm reduction. There are a number of different pots of money that are available, through HRSA for FQHCs, or through CDC for HIV prevention work, or Hep C elimination work that can be used towards syringe services programming. Recently, we had the first dedicated harm reduction grants through SAMHSA in the past couple of years, and NASDAT is now receiving some funding from CDC as a pass-through to fund syringe services programs. So we're starting to see some more resources, but historically, it's been a matter of cobbling together funds from various federal, state, and other sources, particularly to cover those aspects like syringes or cookers, injection equipment that are not allowable to purchase with federal funds. And thank you so much, Ginny, for putting your contact info in the chat. I would love for Andrew and Jessica also, just at some point before we close, you could drop your contact info in the chat for anyone who has follow-up questions.
Awesome. Maybe people want 10 minutes back.
Let's close. I see one last question, so let's close on this one and just hear a few words from each of you, and then we'll close. What gaps do you see in healthcare professional training that impact injection drug use and STI care the most? That's kind of a big question, but maybe we could hear kind of a top line answer from each of you.
I can tell you, as a nurse, I did not learn a single thing about IV drug use or STIs in nursing school. So I think it starts from there. Once I became a nurse, it was upon me to seek that education out. And luckily right now, with the resources we have with the Indian Country Echoes, I've been able to really expand my own knowledge of all things STIs and substance use. And so that is a huge resource for any clinician seeking to learn more.
I'm a pharmacist. I also don't think I mentioned what my profession was earlier. Maybe. I think one of the big things is that health professionals often don't know how to feel comfortable having these conversations and how to have these conversations non-biasedly, so the patients don't feel comfortable having these conversations with us and being honest with us.
And I mean, I think that it's a lot of stigma. I mean, look at, we don't even require an X waiver anymore, but we still can't get people prescribing Suboxone, and we know it works. We can't even get them to begin conversations about it. And so I think that is stigma, which at the end of the day is like a fear and a misunderstanding or lack of education on a certain subject. So I really do think that stigma training is really needed.
Well, I just want to extend a big thank you to all of our presenters today, Jessica, Andrew, and Ginny. Thanks so much for being here and sharing your experiences. Thank you to everyone who attended today. I hope that this has encouraged you to either start or continue conversations with your local harm reduction organization, or your local or state health department, or your local tribe or IHS, depending, where you're coming from. And I will drop in the chat one more time our page for this webinar series. So on this page, you can find recordings of previous webinars. You can also register for the next 2 webinars coming up. On Tuesday, June 27th, we'll focus on state health departments and any innovative approaches at the state level on syphilis and drug user health. And then on our final webinar, Tuesday, July 25th, we'll focus on local partnerships addressing syphilis among people who use drugs. So thank you again, everyone. Enjoy your afternoon.